Go
Good
ahead, sir.
evening, good evening to one and all present here. It's been a great pleasure to have one of our eminent gastroenterology and Professor Dr. Shobna Bhatia ma'am. She has taught many students directly and indirectly, few like me also. So, ma'am, it's a great pleasure for us to have you here in this podium called EGA, which is a small initiative to especially get niche topics which are there in our field of gastroenterology. So, ma'am is has been president-elect ISG. She is a honorary gastroenterology consultant at HBT Medical College and Dr. R.N. Kapoor Municipal General Hospital, Mumbai. She was a former consultant in H.N. Reliance Hospital, Mumbai. Ma'am was former head Department of Gastroenterology at Shed GS Medical College and KEM Hospitals. Ma'am is member of few of the most famous motility units. Few of them to name are Chicago Classification Version 4, Rome 5 Foundation, and Lyon Consensus 2. Ma'am has many works in motility sciences, and pharyngeal manometry is one of a very niche topic, and she is the apt person to take up such topic and give her knowledge to all of us, and hope many young gastroenterologists would be able to take this topic ahead in their clinical practice too. Thank you, ma'am. Thank you for accepting this invitation generously and giving us an opportunity to hear you.
Thank you, Prashanth, for giving me this opportunity. In fact, this is a topic that I love to discuss, but because of various restrictions of the current manometry system, we haven't been using pharyngeal manometry much in clinical practice. So what I'm going to do is this is going to be just an overall overview, and it will just tell you a taste of what pharyngeal manometry can do. But details we cannot cover in such a short time. So we can think of how to increase this knowledge later. Maybe students themselves can start coming up uh, in these presentations and talk about it. So let us see what is the job of swallowing. The job of swallowing is to transport food from the mouth to the stomach. It is something that we take uh, we take it for granted. We don't even think about it when we think of a glass of water that we swallow. But think of the people who cannot swallow. And this is where we can help them at least diagnose some problems rather than, if not treat them. So the original systems that have been there in the market have been the water perfuse systems. We've all used them for many years. They are also used in cardiology. The catheters are robust and cheap, and they have closely spaced side holes. Okay, so now let us look at the solid state. The solid states are not really new because they have been around for more than 30 years, but impedance was added to them maybe about 10-15 years earlier. And there the pressure measured are incorporated into the catheter. So even if a person moves, say, sits up from the lying down position, the pressures don't usually change because this is a problem with water perfuse systems. That the water perfuse systems, you have to apply a hydrostatic correction, and that's a little difficult sometimes. The second thing with these catheters is a pressure rise rate, which is very good. Now, if you look at the upper sphincter, it is skeletal muscle. Upper sphincter, pharynx, and the proximal esophagus are all skeletal muscles. So the speed at which they contract and relax is very fast. And the water perfuse catheters are not that fiddle in picking these changes. They are very good for the lower esophagus. So this is something very important to remember, that the smooth muscle contracts slowly, relaxes slowly, and the water perfuse systems can measure those pressures very accurately. They're simple to use, etc. I won't go into that. So now this is a classical esophageal manometry. I hope the people who are listening have worked on manometry either in theory or in practical. And you look here on the top is this dark red bar, which is the upper sphincter. The lower red bar that you see, which is the LES, resting pressure, and in between is a contraction which is there after a swallow. The contraction, you find that the peristalsis increases, peristaltic pressure increases, so the pressure becomes red. But what you do not see is what is happening to the fluid that the person has taken. So now let's go a little ahead and add impedance to this. So you see this, there is this purple colored fluid that is going down. This is of course an abnormal graph, but you can see that the fluid actually did not go down completely in the first graph and maybe went down up to the lower end of the esophagus in the second graph. So basically, when you have add impedance to a manometry catheter, you can see the bolus clearly. And for many of these things that we do in pharyngeal manometry, impedance is something that you need. Now, what are the symptoms of pharyngoesophageal dysfunction? The most common symptoms that a patient comes with are dysphagia, global sensation, hoarseness, change in voice, sore throat, chronic cough. But these are not symptoms that are limited to the esophageal function. They are also seen in some patients with neurological diseases. Patients with neurological diseases might have cough, they may have difficulty in swallowing, a change in gag, and most commonly, patients with a stroke, post-trauma, head neck cancers might have these problems. Even patients with Parkinson's or patients in chronic care settings would have similar problems. And this is where we might able to help them. So I'll come to the indications later. Now, I have expanded on that graph I showed you all in the beginning, where we were looking at the upper esophagus and the lower esophagus at the same time. So now here, the catheter you can see on the left on an X-ray is in the proximal esophagus. That's the neck X-ray that you are seeing. You see the proximal esophagus, there is the upper sphincter, which is opening after a swallow. That means this, let me check if I can show you all the, unable to get you the pointer. Okay. So you see here the upper sphincter, when it opens, the color becomes green, which means the pressure has decreased. And then you see the proximal esophagus, which is skeletal in character, having a red colored peak. Now, there are few things to a safe swallow. It is dependent on a lot of mechanisms. So, safe swallowing means that the food goes straight from the mouth into the esophagus and there is airway protection. So, if ever the patient starts coughing, we all do if we talk during a swallow, then in that case, there is a chance of aspiration and then the swallowing is not safe. There are two pumps that help the bolus getting pushed. One is the tongue, and the tongue, when we swallow, the tongue hits the back of the pharynx and blocks the bolus from going proximally into the nasopharynx and the nose. And the second is a pharyngeal contraction. The muscles of the pharynx contract and pump the food down across the upper sphincter. So bolus clearance occurs when there is a good upper sphincter opening and there is an effective pump coming from above. Now these are the muscles of the throat and the neck. So there are three pharyngeal constrictors, the superior, middle and inferior. There is the hyoid bone, the thyroid cartilage, the cricoid cartilage, which is most important for us. And there are one muscle that we are very, very careful about is the cricopharyngeus. So just keep this picture in mind when I show you the next slide. Okay. Now you see the oral cavity, which is above the tongue. And on the left side, you see the hyoid, the thyroid cartilage, and the cricoid cartilage. On the right, you see the epiglottis, the laryngeal inlet, the arytenoids, and the esophageal inlet. And you appreciate that just about above the larynx, the cavity is a common cavity. When you swallow or breathe, it is the larynx and the contraction of the cricopharyngeus that decides where that substance goes. If the upper sphincter is closed, whatever you have, even if, I'm talking about air during breathing, will go into the larynx. The cricopharynx has to be elevated to be able to open the upper sphincter. If the cricopharynx is fixed, this is seen in patients who undergo radiation of the neck. The cricopharynx gets fixed. The cricopharyngeus does not elevate the upper sphincter, and the patient lands up getting aspiration and difficulty in swallowing. So now imagine that picture we saw in the beginning. So the first thing on the left, you see the bolus entering just above the tongue, and you see that that is the glossopalatal junction. On your right, the first right, you see the velopharyngeal junction, where the tongue is starting to approximate backwards to the pharynx, and this takes these all are fraction of seconds. The whole thing is over in less than 1 second. Velopharyngeal junction time is about 0.16 seconds. This is rough timing. The next thing the bolus enters is the laryngeal vestibule. And you can see that the arytenoid is there, and the bolus is pushed behind the arytenoid. Because when the upper sphincter elevates, the larynx closes. And then when the food hits the upper sphincter opens and the bolus goes through. So when you see all these timings together, you see that in less than about 0.5 to 0.6 seconds, the bolus has already crossed the upper sphincter. So the specific constraints of a manometry are, one is the sequences are very rapid. That I already spoke about. There is a complex anatomy, geometry. The upper sphincter is not round, it is axial and spreads from in the sides. When you do an endoscopy, you see that when you want to enter the upper sphincter, if you put your scope in the middle, you can't enter unless the patient swallows. There is a UES pressure asymmetry. The maximum pressures are in the anterior-posterior direction. And the upper sphincter tone is very labile. When you are stressed, automatically you start feeling like a globus there. And subtle stimuli can increase the pressure or decrease the pressure. So now we need a little more data about all this. Let's leave it. Now let's look at the structures here and what is happening. So on the left, you see a picture of a radiology. And on the right, you see what is the parts of the manometry, parts of the upper sphincter that you see during manometry. This is a temporal graph. You want to understand this. Remember that the upper sphincter has to be open when the bolus is going to come. It cannot open after the bolus comes. Because if it opens after the bolus comes, the bolus will automatically skip into the larynx. So this physiology is a very rapid physiology. So this, let's go through the parts. Okay. The first part here is right now the bolus is somewhere in the mouth. And as soon as the bolus crosses the base of the tongue, the upper sphincter starts to open. Okay, I'll come there. So the first thing that happens is a velopharyngeal closure. And that pressure that you see on the top, which is put in a square, is a feature of the velopharynx. Then that is the tongue base, and that is the pressure generated there. Then the hypopharynx contracts. And if you notice at all these points, the upper sphincter is already open. But something else happens here. So these are the things that you will measure here. I'll be coming to that later. Now, in the resting position, the upper sphincter is a red bar like that. But when you pre-swallow condition, it is stable, it is contracted. Now, if you look carefully in the middle, the upper sphincter actually elevates itself. And therefore, when you are doing the manometry, the channels in which you measure the relaxation are different. That means the proximal channels. So the relaxation is measured 1 centimeter above the actual upper sphincter pressure. And you'll see it here. Upper sphincter opens. It has already risen above. And you see this, that is, so it's rising above and then it comes down along with the laryngeal elevation. Now the upper sphincter is open for less than 5.5 seconds. And that is the point where we measure the integrated relaxation pressure, exactly like the way we measure it in the lower esophageal sphincter. So this was the pressure that we were measuring. Now let's look at what happens when we look at the flow. So when we add impedance, we look at transit and clearance. And when we are doing an isolated pressure analysis, we look at the contraction and relaxation of the pressure. When we do a combined analysis, then we know what is happening to the bolus at the same time that the upper sphincter is contracting or relaxing. Isolation, if we do, we cannot measure the coordination. So the one thing that in this analysis that we look at is the peak pharyngeal pressure and the pressure when the impedance is the least. When the impedance is the least, it means that the flow is the maximum. And that is the time when the upper sphincter is actually distended and allowing the bolus to pass through. So this is also called the bolus distension pressure. And if the upper sphincter is not open, then that intrabolus pressure actually rises, giving the feeling of dysphagia. So this is the same thing in a different format, and this is the flow interval. Okay. Happened to this. Okay, sorry. I think my computer froze for a moment. Okay, now look at the left here. You see that these contractions, you see a few things here. And as I mentioned earlier, you can make out which part of the upper sphincter or the pharyngoesophageal segment is contracting. So the nasopharynx, there's not much pressure there. You look at the left. Okay, you can look at it as a line plot, which is the old-fashioned way of looking at manometries. But sometimes that is useful to see how the direction is going. First is the naropharynx, then the velopharynx, the mesopharynx, and the hypopharynx. So hypopharynx, we also look at the peak contractility. And then the upper sphincter, which is opening and closing again. Now, when you add impedance, you see on your right, this is the distension and the contraction plot, which is a concept that has come up in the last 10 years. that unless that area distends, the bolus will not go through. Okay. And this is the bolus, and sometimes that is expressed as what we call as admittance. We know about impedance, but the inverse of impedance is a term called as admittance. That means the upper sphincter allows the bolus to be admitted properly through it. So you look down on your right lower part, and you see that there is peak distension of the pharynx. That is the admittance. That means the pharynx has made enough place for the bolus. And the intrabolus pressure is the black line under it. Now, one thing we need to know is that the pharynx has a lot of capacity to distend. In normal life, we may be having 10 ml swallows. A bite is a small bite, but we are also capable of swallowing an entire pani puri, which is a large-sized bolus. So the pharynx does make place for that. The upper sphincter does admit that large bolus. So therefore, if you give small boluses, you are likely to miss abnormalities in the pharynx. I'm not saying give a large pani puri, but yes, 2 ml boluses really don't work. We have to give larger boluses sometimes. So before going into actual protocol, I'll just tell you all what are the parameters we measure. So we measure the intrabolus pressure just above the upper sphincter, which is called the hypopharyngeal intrabolus pressure. If it is elevated, it means that the upper sphincter is not relaxing, or there is a delayed relaxation. That means the pharyngoesophageal segment is incoordinated, like happens in Parkinsonism or in strokes. Then the upper sphincter integrated relaxation pressure is exactly like the pressure that we measure in the lower esophageal sphincter. It is the same. UES maximum admittance, I told you all, it is the admittance value, which means it is the amount that the upper sphincter is able to open during the sphincteric bolus flow. And the relaxation time is the time that the sphincter remains open. There are parameters to measure it. I won't go into that right now. In the pharynx, the things that we measure are the contractile integrals of the velopharynx, the mesopharynx, and the hypopharynx. And this just tells us what is the contractile ability of these segments, because a patient with a weak pharynx, after multiple uh, uh, cranial nerve paralysis, the bolus is just not pushed and the patient tends to aspirate. Now let's come to the most important part. What are the indications of doing a pharyngeal manometry? Now, when you are doing any manometry, you know that you also keep uh, one sensor in the upper sphincter to see where the swallow is starting. In short patients, you can actually see the entire pharynx uh, and also see the LES at the same time. In patients who are tall, if you want to focus on the upper sphincter, then you quite often miss out on the lower sphincter parameters. So when it is strongly recommended, so either the history or other tests like the VFSS and the FEAS are abnormal. Now, sometimes it adds value to VFSS and FEAS, and you can test what kind of bolus a patient can have. I've not gone into the parameters that change with change in position, because then this would be a very long lecture. And you want to, in these cases, you want to quantify the propulsive and the restrictive forces. And sometimes this helps our speech swallow therapists to determine the baseline swallowing function and how to help these patients. The other place where this is important is when you want to do a therapeutic intervention like a myotomy, a Botox injection, or dilatation, and you want to see what the result will be, or for rehab treatment. That is where many people use it. Of course, it could be done when VFSS is difficult or cannot be performed in a patient because ultimately VFSS, the patient has to be shifted to another area. Whereas technically, the machine can be moved to the ICU and the procedure can be done in the ICU. In patients with functional dysphagia, quite often the VFSS may not show up an abnormality. And in some patients, like those with a degenerative or a neuromuscular disorder, you may want to actually quantify and see the objective changes over time. And there is where it is help. Now, where do you not do it? The first is there is nasal obstruction, trauma to the nasal cavity or whatever, or high risk of bleeding. You don't want to add trouble to a patient who's already sick. A patient cannot follow commands. So that is one part. Or the patient keeps on gagging, coughing for whatever reason. Now, if the patient is already having an aspiration, then there's very little to do in a pharyngeal manometry because you already know that this patient has an aspiration. And by adding a large bolus size, we are going to increase the chance of aspiration. So therefore, it is best not to do an HRM at that time. Now, in patients where there is no obvious aspiration, certain techniques can help us check the risk of aspiration. I won't be discussing that today. Now, I want all of you to download these two articles, which are free. Please write this down. This is the consensus on how to do it and how to define these parameters. The parameters are there, and how to, the analysis of the parameters, of course, is not there. You have to go backwards and read the articles. This is from, of course, it's mentioned the Leuven group, but this is an international guideline come from all the people. So this is another article which was published a few years ago. This is from Ravinder Mittal and Tahir Omari, the first and the last authors, who have been trying to work together on this to come out with analysis of the upper sphincter and making it more standardized. Recently, the Chicago group also has come up with what is called as a 4D manometry and also looking at distension contraction plots. Basically, in upper esophageal manometry, there should be two things. There should be a distension in the upper esophagus and the pharynx so that the bolus can go through. And after the bolus goes through, there should be a contraction. And therefore, these plots are called as distension contraction plots. What is the protocol that you should follow here? So the main thing is that patients should not be lying down. For upper sphincter manometry, patients should be in a sitting up position. And if the patient can tell us, in most cases they can, we ask them what is the kind of liquids they can swallow easily and then test them accordingly. Because as we increase the viscosity and the amount of the bolus, these are actually stress tests for the upper sphincter. So we usually start with say 3 10 ml thin liquid boluses. And if the patient can tolerate, we give 20 ml boluses. Now, unlike the lower sphincter and the esophageal body, the upper sphincter manometry, between one swallow and the other, there's not much variation. So 3 swallows are enough. In the smooth muscle does not repeat the manometry, all the waves don't look similar. In upper sphincter, they quite often look similar. Therefore, you can give only 2 or 3 swallows and you can derive values from it. If the patient is able to take a good amount of thin liquid, that is 20 ml, then in that case, viscous liquid, can be tried. Okay. Now, based on abnormalities that happen in the upper sphincter, there is a classification which you all can all see later, is similar to our achalasia classification, where there can be pan pressurization, transient pressurization, or no pressurization. This is just to tell you all what kind of parameters we can look at. Okay. And this is how you analyze it. So this is a decision tree to see how to evaluate patients. Patient has oropharyngeal dysphagia. If the patient already has a VFSS done and you have a plan of what treatment to do, then go ahead with the planned treatment. There is no point in trying to add another procedure to these patients. If it has not been done and the patient has a low risk of aspiration, then do a video or a plain pharyngeal manometry. If there is no risk of aspiration, if there is no risk of aspiration, you can go ahead and do a FEES. And of course, if the FEES is already done, then you want to analyze other parameters like looking at the amount of pharyngeal residue, a delay in bolus transit, then in that case, you can do a standalone pharyngeal high resolution manometry. The other tests that are complementary are the upper airway endoscopy and a sensory testing, which may or may not be done. So this is the contractile function. Okay, so in conclusion, it is a good diagnostic test and it can quantify physiological processes that can drive radiologically or FEES detected pathology. You can actually identify the physiological process. It can be implemented in clinical care. It can be done as a bedside evaluation and has a value in decision making of dysphagia management, which I have not touched upon because this would have extended the lecture too long. And of course, if you follow the protocol and the analysis that is mentioned, then in that case, it would be a much easier thing. Thank you.
Thank you, ma'am. Thank you for the value-packed session. It's just a starter's course.
Okay,
Ma'am,
chalega.
ma'am, wonderful session. Thank you for this rare session. Pharyngeal manometry is something as gastroenterologists we are least exposed to it. So you have really started the light, and hope many of us would be able to carry it forward for our practice with more deep learning and understanding the physiology. Slowly, there are some gastroenterologists who are picking up fees and are able to do fees in their centers. Like I have recently started doing fees in my center, and that is when we realize swallow is also such an important aspect of life. So, ma'am,
It is
thank
the
you.
most difficult one. It is the
Uh,
most coordinated and the most difficult to understand.
Absolutely, ma'am.
Yes.
Absolutely. So, especially when there are patients for rehabilitation
Hmm.
and when they come up with different issues, we see the variability of what a face can tell. It's just phenomenal, and we always feel nature has so complicated that we'll take a long time to figure it out. Definitely, with your help, I think many would take this up as a topic of interest to go ahead and get more interested in this niche topic, ma'am.
Hmm.
So, thank you, ma'am. Thank you.
Okay, any other questions?
Ma'am, there are many questions
We
actually.
can start, no problem. We have 10 minutes.
Absolutely. Ma'am, Dr. Manmohan from Bangalore has asked a
Hmm.
question. Can we use the same manometry probe which we use for esophageal manometry?
It is the same probe.
Okay, cool.
It is the
So,
same probe, and whatever softwares are there, some of them have a built-in uh, uh, upper sphincter manometry analysis also.
so we use only solid state manometry, ma'am, because there's that water which keeps coming. So water perfusion is a total no-no for this.
No, I didn't say that. I
Oh.
said that with water perfusion. Okay. So, with the solid state, what happens is the fidelity of the upper sphincter, because the upper sphincter contracts very fast. you see in less than zero point 0.5 seconds, the whole swallow is over. And these segments may not be well seen with a water perfused catheter.
Okay.
The other thing, when you try to do a hydrostatic correction, sometimes you may not get the exact values that you want.
Okay.
And plus, the main problem is in the fidelity of the catheters. So I made it clear that for lower esophagus and smooth muscle of the esophagus, water perfused is fine, except that you can't add impedance to it.
Okay. So
But
addition of impedance makes
yeah,
a
so
big difference.
solid state and addition of impedance. Now, let me tell you that there are some companies, even with water perfused, they do have some impedance there, but those catheters are very thick and hard.
Mm.
So I used to try and place them, and patients used to always be grumbling that they were very irritating in the throat.
Okay. Okay.
Okay. The other thing, what I didn't mention, and I'm very sorry about that, is that when we are trying to do impedance, we don't use plain water. We use saline. Because to measure impedance, you need ions in the fluid that we take.
Okay.
Yeah. So you can use most of the data that are available are with half normal saline. And there are some data on full normal saline also. Okay.
Okay. The next question is by anonymous attendee. What is the role of upper esophageal sphincter manometry in evaluation of swallow disorders in post-laryngectomy patients?
So there is again that you measure the pressures, but how much it will help, it is mainly the swallow therapists who come in at this stage.
Yes, ma'am. Swallow.
Okay, you're not going to get much pressures. And patients who have laryngectomy, the problem comes up when the larynx is out, the cricopharynx becomes dysfunctional if it is still in place. Otherwise, sometimes the cricopharynx is also taken away. And then the patient, the upper sphincter doesn't elevate. So you see, I'm just showing it. The upper sphincter has to elevate. So as an experiment, what all of you can do is hold your larynx, try to swallow. And as soon as you swallow, the larynx will move up. When the larynx moves up, it closes. The upper sphincter opens. Oof. Okay. So one of the tricks that you can use in a patient who is not swallowing during endoscopy and is awake, tell the patient to cough. When a patient coughs, cough is reflexly associated with a swallow. So you cough, and the next thing you do in the next 2 seconds is swallow. Soon as you swallow, the scope goes in. And the patient swallows, the scope goes in. So these are just tricks.
Nice trick.
Nice.
Thank you,
Okay.
ma'am.
Next
Thank you.
question. Next question.
Next question is by Dr. Shivraj. He has asked, is there any different protocol for solid state manometry?
No. The protocol that is there from the Chicago group is for both. But there is a caveat there that for water perfused manometry, you cannot comfortably make the patient sit up.
Okay.
If you can with the hydrostatic pressure changes, it's fine.
Okay, cool. So Dr. Shailesh Sharma has asked, where is Pharyngeal Manometry device available? I
It
think
is the same machine that you use for regular manometry.
regular
There
manometry.
is no other device.
Okay, most of the questions are same manometry probe which we use for
Yes,
esophageal manometry.
absolutely. Absolutely. Just withdraw it a little bit and you will see that the upper sphincter will come in the center of your screen.
Okay.
So you can see all the parts. And in a short patient, you can see the upper esophagus and the lower esophagus at the same point.
Then they're asking, what are the clinical indications for pharyngeal manometry?
I think I showed the indications on the screen. There
Yes,
is
ma'am.
basically patients who have neurological problems, patients with persistent globus sensation, may not have dysphagia, and you want to find out whether there is a true defect or not. Now, if you have done FEES and it is grossly abnormal, and you can manage your patient with the data that is available from FEES, you may not go ahead to a manometry. Okay, FEES is more subjective. Manometry is more objective. You can see the pressures, you can see the flow and write down values. So that is one of the differences.
Okay. Ma'am,
So I don't do FEES. I don't do FEES. I have not trained in it.
Okay.
Okay.
Ma'am, when I have done fees, where I've seen it's most helpful is frank penetration, aspiration, even with liquids. Then there is a direct shift towards peg placement, where there's no point in thinking for these patients peg placement directly when we do it and then explain to the patient, because swallow therapy also has some limitations in few subset of patients.
Absolutely.
So there
Absolutely.
it is. There's a easy decision making which happens. We even see some patients coming with Riles tube feeding for 6 weeks, 6 months, and then getting it done because they have been shifting different centers, and then come and then the decision is made. So all these places, I think definitely it would play a role.
Yeah. So when there is obvious aspiration, don't do a manometry. When there is subtle aspiration, you're not sure whether there is aspiration. This is where it helps the most. It will actually, we didn't go through all the pathological variants of the pathological abnormalities, but in that you can actually predict how or which this patient has what percentage risk of aspiration. The other thing you can see is how much is the residue that remains in the pharynx after the swallow is over.
Yes, ma'am. True. There also it helps when there's accumulation and the nature is so different for solids and liquids also. The kind of accumulation that happens, even salivary pooling which happens, are all slightly different, which we'll have to unravel over time. Uh,
Yes.
yes, ma'am.
Okay, so other thing like you said about the kind of solids that you give. So sometimes you ask the patient. So you remember that the upper sphincter requires more effort when the solid is dispersed. The example I can give is of rice which is spread. The bolus is not formed well. Okay, if the bolus is formed well, it is easy to swallow because it goes down as one piece. Pharyngeal coordination is more necessary if the bolus is likely to break up. And that happens with things like poha, rice, something that is powdered. So, in such patients, you could actually check out and ask them if they are comfortable taking certain type of swallows. And that the swallow therapist really, really helps in these cases. And why I am saying this is that the best of patients, the worst ill patients would always like to swallow through their mouth. Okay, you give them a choice. If they can't take too much of liquids, they aspirating the liquids. There are things like changing the position of the neck while swallowing. Okay, patients who are aspirating at night, there is a device called as Reza's device. REZA. People should read this up. The device actually pulls up the larynx. It's a laryngeal elevation device which is worn by the patient. And because of that, when they don't wear it, they don't elevate the larynx completely, but the larynx is elevated midway. So patient doesn't aspirate at night. Otherwise, pooling of saliva occurs at night. So these are very important advances that have occurred in this. Okay.
Definitely, ma'am. Uh, Thank you for the time. There are some requests for further sessions to teach pharyngeal manometry step by step. Of course, we will consider that over time with ma'am's permission, and because it's an entirely new subject for
Yes.
majority of us. So, thank you, ma'am. Thank you for exposing us
Thank
to
you.
a new physiological domain for all of us.
Thank you. Thank you very much. And I'll tell you again, go back to the two articles that I pointed out. They are eye openers. Okay, this, of course, the first article from Tahir Omari's group, which is actually the whole consensus from the global consensus, is something that tells you what are the potentials, and you can go backwards and read all the references which have started about 20 years ago. Okay, yeah. Thank you.
Sure, ma'am. Thank you. Thank you.
Thank
Have
you.
a nice day.
Thank you very much. Yeah.
Thank you all. So, we will be getting back with further new topics. So, over time, we may even have swallow therapists talking about what are the different things they are going to do and what are the different parameters they get to see and assess and understand the physiology, complex physiology much more. And I really thank ma'am for giving this great opportunity to listen to ma'am and just get that ignition, which is most important for all of us. Thank you, ma'am. Thank you. It's our pleasure.
Thank you.
Thank you.
Thank you. Thank you very
Thank you,
much.
ma'am. Thank you.
Bye.
Yes, ma'am. Bye.